A 64-year-old patient presents with progressive abdominal pain and fullness. I am showing you the abdominal radiograph. Describe the findings.
Okay. The abdominal radiograph demonstrates diffuse, generalized osteosclerosis affecting all visualized bones of the pelvis and spine. There is also a huge soft tissue shadow occupying the upper abdomen and extending into the pelvis, representing massive splenomegaly. The combination of generalized osteosclerosis and massive splenomegaly in an elderly patient is highly characteristic of myelofibrosis. Other less common possibilities to consider are lymphoma and mastocytosis.
What is the differential diagnosis for generalized osteosclerosis in adults, and how do we differentiate them?
The differential diagnosis for generalized osteosclerosis includes sclerotic metastases, lymphoma, myelofibrosis, Paget's disease, renal osteodystrophy, sickle cell disease, mastocytosis, osteopetrosis, and fluorosis. Sclerotic metastases are patchy and associated with a known primary, like prostate or breast cancer. Paget's disease displays cortical thickening and coarse trabeculae. Renal osteodystrophy exhibits subperiosteal resorption and a Rugger Jersey spine. Sickle cell disease presents with H-shaped vertebrae and splenic atrophy rather than splenomegaly. Osteopetrosis shows a generalized bone-within-bone appearance and sandwich vertebrae.
I am showing you comparison radiographs and CT images of other osteosclerotic conditions. Describe the findings and how they relate to the differential.
In that case, the axial CT of the pelvis shows marked sclerosis of the hemipelvis with cortical thickening and coarse internal trabeculations, typical of Paget's disease. The first comparison chest radiograph demonstrates diffuse uniform osteosclerosis in an adult with osteopetrosis, where the intervertebral discs remain clearly visible, confirming true osteosclerosis rather than an underpenetrated film. The second chest radiograph shows diffuse osteosclerotic metastases from prostate cancer in a male patient, along with gynaecomastia secondary to hormone therapy. The last dental radiograph demonstrates dense osteosclerosis of the mandible and multiple supernumerary teeth, which is a classic associated finding in osteopetrosis.
Discuss the pathophysiology of myelofibrosis and the clinical implications of massive splenomegaly.
Well, myelofibrosis is a chronic myeloproliferative neoplasm characterized by progressive reactive bone marrow fibrosis mediated by clonal megakaryocytes releasing fibrogenic cytokines. This marrow fibrosis leads to progressive hematoerythroid failure, resulting in severe anemia. To compensate, extramedullary hematopoiesis occurs, primarily in the spleen and liver. This causes massive splenomegaly, which clinically presents as early satiety, weight loss, and left upper quadrant abdominal pain. The osteosclerosis is caused by secondary osteoblast activation and trabecular thickening adjacent to the fibrotic marrow.
How would you manage this patient as a radiologist?
Okay. As a radiologist, I would recommend comparing this abdominal film with prior imaging to assess the progression of splenomegaly and osteosclerosis. I would suggest obtaining a dedicated CT scan of the abdomen and pelvis to evaluate the spleen volume, check for portal hypertension or splenic infarction, and evaluate for hepatomegaly. I would also recommend a chest radiograph to evaluate for extramedullary hematopoiesis in the thorax, such as posterior mediastinal masses. I would communicate the finding of myelofibrosis to the hematology team to coordinate a bone marrow biopsy and plan supportive therapies or splenectomy.